All right, well, welcome to the November 15th HIECC meeting. We anticipate this being a long meeting, but that's not we are not intending to make it long. So if we can be quick on our topics, certainly appreciate. Well, again, welcome. The meeting is being called at 12:18. And can I get a roll call? Pam, can you do that for us?
I can.
This meeting's being recorded.
Craig Dalton.
Here.
Tab Harris.
Present.
Yvonne Amani. Dr. Amani. Okay. Angus Bansell. Dr. Bansell.
Yeah, he's here.
Okay, we got that.
Unmute him.
No. I'm unable to unmute. Can you move him over, please?
Yes.
Melanie Brown Wolfter. Jared Fowler.
He's joining.
Dennis Hollingsworth. Peter Kress.
Here.
Peter. Alex Ramiro. Marie Reddy.
I'm here. Good afternoon.
You. Helen Serrani. Kim Straight. Kimberly Tendridge.
Good afternoon.
Melissa Bergeson. Simon Zucker. Dr. Zucker. And we do have a quorum and just representing the Behavioral Health Association. Linda McDonald is here for Melanie Brown Wolfter, and for the Department of Health, Bruce Culpepper is here for Dennis Hollingsworth.
Yes.
We do have a quorum, Mr. Chair.
Okay, thank you, Pam. We get a review and approval amendment of the minutes.
Dr. Who?
Has everybody had an opportunity to review the minutes? And if so, if there's any questions or corrections that need to be made, state so now. Can I get a motion? Can I get a motion to approve the minutes? I got one from Kim.
So moved. Second.
And I just want to announce the meeting is being recorded.
Meeting is being recorded. Should have made that announcement early.
Okay, sorry, I didn't hear it. Just want to make sure.
Got a motion. Ms. Street, and who was the second? Tab? All right, all in favor, say aye.
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 Minutes are approved. Okay, we approved previous action items.
The only previous action item that we had was for the HIECC members to provide any additional input related to the mental health task force collaboration that was presented at the last meeting. And although we didn't get additional input from the members, staff did learn of a project that was being done or that is being done in Broward County by the Broward Behavioral Health Coalition. And so we did connect that group with the Northwest Florida Mental Health Task Force for collaboration. So hopefully there can be some synergy in the work that you guys did at that meeting and learned about. And we'll double check in on them and see what occurs from that. So, and that's all that we have for follow up from the previous meeting.
Yeah, thank you.
Okay. And then as far as agency updates, we really don't have a lot to share at this time. We do have the legislature has their committee meetings going on right now. So we are really busy looking at and following the different bills that have been filed. We really don't have anything that has been directly related to HIE this year yet. But we are following anything that would impact the agency, and we'll provide an update any of that information goes on. We are also still working to develop our invitation to negotiate for the Florida HIE service vendor. And we still anticipate the ITN, as we call it, the invitation to negotiate, to be put out in January of 2024. That's it.
He's talking about the screen, the presenter mode.
I know, it's in presenter mode, but then it shows different thing.
It's fixed now.
It's doing it backwards.
Okay. So are you
It
seeing?
was, but now it's fine.
Okay, it's fine. So where are we at?
Election officers.
So we did send a notice out to get nominations for officers for the HIECC for 2024. I know last year we didn't elect officers. With the first meeting, we didn't get officers in. We had a little bit of delay because we were just re-establishing the HIECC because we hadn't met in a little bit. We did get 2 nominations for chair and a nomination for vice chair. So both Craig Dalton and Marie Ruddy were nominated for chair. And then Marie Ruddy was also nominated for vice chair, and both have accepted the nomination. I guess we're going to have to do I get a motion, Mr. Chair, for a vote for chair.
So
Can I
moved.
get a motion for a vote on chair?
Motion to vote.
Kim Stride, I would like to make a motion for chair, do I name?
Mm-hmm.
For Craig Dalton to continue the fabulous work that he has been doing.
Get a second?
Second.
Okay, can we get a,
I know it feels weird, but
yes, it's a little awkward. Can we get a vote on that? All in favor, say aye.
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 Any opposed? Okay, now vice chair, can I get a motion for
ready.
Marie Ruddy?
Motion.
Second.
Second.
Didn't catch who the second was on that.
I
There's
think you had
2
2
of us.
seconds. Kim Tendrich is one of them.
Okay, can I get a vote? All in favor, say aye.
Aye.
Any opposed? Okay, it's unanimous. Okay,
Congratulations.
all right. Hey, Marie.
Condolences, whichever.
Thank you. Okay. Thank you, everyone, and we'll keep this meeting moving. The legal work group update, if you're following the agenda, that's the next item.
Okay. So the State Consumer Health Information and Policy Advisory Council did ask the agency to reestablish the HIE legal work group, since we were looking at the re-procurement of the HIE vendor and looking at the infrastructure of the HIE and modification. So just taking a look at any policy considerations, asking them to look at any policy considerations. And so they did meet on October 10th to discuss the HIE vendor transition and look at the policy considerations and any security considerations associated with that. Specifically, they looked at the HIE infrastructure as a whole, data retention, and the consent process. So there were, and there is a summary in your materials, so hopefully you guys had an opportunity to read the summary in more detail. There related to data retention, there were some concerns for the work group members about data security, if it was stored for more than 2 years, and the risk placed on the business associate or the vendor around the data being held. But our current vendor, Point Blank Care, emphasized that their focus on security and risk management. And so, the input back to the agency really was around, just making sure there was security around any data that is retained and the ability for the hospitals to request the ability to purge their data after a certain period of time. And I know the SHIP Advisory Council actually had suggested putting some flexibility. There was an addendum that was approved by them. That's a voluntary addendum that hospitals or data sources can currently agree to retain their data now. And in that language, there was flexibility that folks could have their data purged after a year. So just maintaining it for a year or allowing it for a longer time if they were comfortable with that. So we wanted to, the advisory council was already, looking at and ensuring there was flexibility around that. When we did discuss moving from a Florida-centric model that we have right now to moving to a national network model that was vendor-centric network, that the legal work group did emphasize the need for there to be high trust compliant, the vendor be high trust compliant, and ensure that data moving from state to state was able to meet all of the legal requirements between those states. And of course, that brought us into our consent policy here in Florida. And our consent policy in Florida has always been that the receiving entity must obtain consent, because we could not, for the counter notification service, could not guarantee that those sharing the data had gotten consent from the patient. And in Florida, we do share behavioral health data, mental health data. And so the law here in Florida is that there has to be expressed consent by the patient in order for that data to be shared. So the current vendor did say, express that they do have folks that work to make sure that all of the requirements are being followed. But if we did move to that model of sharing outside the state of Florida, we would need to modify that consent policy to require entities that are sharing the data to receive consent. So that is something that was discussed, and I'm sure we'll discuss further today as we get into that.
Clarify something. Consent to send or consent to receive?
Right now for ENS data, it's consent to receive.
And
So-
to change that, does that require legislation? Or could it be done?
That's a conversation, that we still need to have. It could, we could potentially, and I know we're going to get into that in more detail because we had that as a specific topic. So let's kind of hold that. So
I just want to make sure I get the number.
yes. The only other input was really that they, from the legal work group and also from the advisory councils, they wanted us to get input from the folks that are participating in using the counter notification service, which we did, and I'll be sharing that information with you here in just a moment. Yes. Yeah, that's all I got. Oh, wait, no, it's not. They also, sorry, the legal work group also advised the agency to consider a comprehensive review on moving data sources from opt-out to opt-in, because a lot of hospitals on the opt-out model. So, that's something, if we did modify that, that's something, and that's part of the reason we want to have the conversation today, looking at what would be the operational and technical implications for providers in doing that. And and the legal work group is also meeting again, this Friday. From the current vendor, we do have some recommendations for modification to the ENS agreement. And really, we're gonna look at that for input, in moving forward with our ITN rather than modifying the agreement as it stands right now. But it will help us as we move forward and we look at a new vendor and what we would need to do in modification of that ENS agreement. Now I'm complete with that.
I don't know how many current members, I served on the legal work group, when we were doing the original patient lookup with Harrison Court, as that was being set up. The work that's being done there, and I don't know who's all on the committee, but that is yeoman's work that they're doing within that committee. And their recommendations, and they're gonna need feedback all the time as this thing becomes sorted out, because there's a lot of stakeholders involved. And to make sure that the legal work group is making accurate recommendations will require a lot of feedback. So this discussion coming up is super important for all parties, and not just for the vendor, just for vendor selection, but also just for the state's priorities and where the state's headed. With that said, that the Pam's team has been doing some outreach and basically doing listening sessions with various stakeholders throughout the state that are doing either clinical data exchange, that are providing ENS data, various source hospitals, hospital systems, to see what, to get some good feedback to help shape this conversation. And so I know Pam's got some updates on that. And is that on the slide for anyone to see, or?
Yes, I am going to. Okay. Yeah.
She's going to change it.
Okay.
Share the screen.
It's not letting me. I know. Okay. Here we go. So, the agency, staff has been, looking at or reaching out, and, we did, send out a survey to both data sources and data subscribers of the ENS service, and got back limited responses to the survey, but we did get good feedback. In addition to the survey, we held listening sessions. We held listening sessions with Department of Health, with our regional health information exchanges, health plans practitioners, all of our subscriber groups. Is it not showing my screen?
It is.
It is? Okay.
It is on there. It's
Okay.
not in here.
I'm so sorry that you guys are not seeing the screen. I don't know why.
It's online.
You have to connect to the projector.
Oh. Okay. Okay. the slides will be sent out to you. I just didn't get them done in time because we were still doing listening sessions up until last week. And actually, we're still getting input from some stakeholders, directly. So, we did, get some key points for every topic area. And really, we broke down the topic areas by data retention, interstate data exchange, and then consent. And then we asked for really kind of some general concepts about the Florida HIE and things that we could do to improve. So some of the key feedback around retention of the encounter data was that there was, for that to occur, folks were adamant that the vendor be at a minimum ISO certified with a preference for high trust certification. That the time for retention be limited. One of the things we heard was that they wanted the data maintained in the lower 48 states, which is interesting. Assurances that the data not be monetized or sold, and then clear definitions around the data destruction after the retention time is run. So those were just some key things that we heard from all of the folks that we talked to around data retention. There really wasn't any pushback to retaining the data. It was really kind of neutral and more dependent on how the data was used versus the actual concept of it. When it came to interstate data exchange, there was really a limited interest in interstate encounter data exchange. We did have some folks that were in the northern part of the state that expressed interest in, getting data from Alabama and Georgia, that could potentially be beneficial. Some providers in the southern part of the state were interested in getting the snowbird data. But in general, the providers expressed a need for better, and I hate to use the term quality because, but I mean, that's the better quality data versus additional data from other states. And so more complete really is what they were referring to when they say quality. Like if they're getting information from a hospital, make sure it includes the discharge disposition and the diagnosis codes and that type of thing versus getting more data. Right. We did hear that from some folks that we're getting a lot of data, but it's sometimes it's, yes, ma'am.
Sorry, I didn't mean to interrupt, but did you see differences by type? Since you talked to a lot of different groups, did you see any differences on this interstate exchange, or was it pretty much universal that there wasn't that much interest, that it was more about improving the quality?
So the folks that we did hear from that were interested, this was kind of interesting. It really depended on how they were using their ENS data now. So folks that maintain their data now and do data analytics and that type of stuff with their data, there was more of an interest in getting that interstate data. For folks that use it for specifically immediate action, like we use it for, if there was an encounter, we reach out to the patient and do something with it right now. There was more of a, I don't really see, there wasn't as much value, although there was a, yeah, it would be nice. It wouldn't hurt kind of thing. So.
Make your Kim's questions without.
Did you guys hear Kim's question?
Yes, we heard it.
Okay.
Oh, good.
Anxious and friends.
Your voice carries.
Are there any other questions from the members about that? Regard to consent, there was in discussion of changing consent, that kind of thing. Respondents did express that behavioral health data, because the correlation with the consent is being able to share interstate. There was input that behavioral health data was more important than interstate data exchange. Among Florida providers, they would rather have more behavioral health data than get data from another state. Some key points there were that the current consent model works for the existing ENS infrastructure and being able to get that behavioral health data. We did hear from hospitals that a lot of them have recently moved to opt-out models, which would not allow for that expressed consent. You would have to have an opt-in model for express consent to be met for sharing of behavioral health data. Another thing that was expressed is there was really alignment needed with federal changes to make sure that we are in alignment with what's going on federally to help them minimize cost and impact from the IT infrastructure perspective. I don't have a lot of details on that. That's something we probably need to delve into a little bit more on what are we doing that isn't meeting those federal requirements, or what are providers, and hopefully when we have this conversation and we move into this, what are some of those federal changes that are going on and sharing of data that we need to look at here in the state of Florida to ensure that we're aligning both at the state and the federal level. When we talked about enhancements, just, those general things, what can we do to improve what we're doing and provide more information or provide better data? There was interest when we actually asked about specific potential services. There was interest in having information about care team information, who else is working with the patient, right? So, if I'm the primary care provider, who is their health plan, who is their, or ACO, or, if I'm the skilled nursing facility, who all is working with this patient, that type of thing. Census reporting, what's going on with this patient, and then readmission risk scores. So, those were all of interest to those folks that we talked to and surveyed. Practitioners, so those primary care providers in particular, expressed interest in improving the data currently being sent to them, and including in really being able to get the discharge summaries and or medication histories from hospitals. One of the things that we heard a lot from the practitioners is we get a lot of data, but we don't get a lot of information. They're getting data overload because you'll have practitioners that get notifications. Maybe they subscribe to the encounter notification service. They also get notifications from their health plans in a different format. They also get notifications directly from the hospital because the patient will have said, because of the law that says that the hospitals have to ask the patient now if they want the information sent. So primary care providers are getting notifications about the patients in overload. But it's all coming in different ways, and and typically it doesn't provide the information that they need to work with that patient. So that was something we heard loud and clear, and that they're getting too much information, but not the information that they need, or too much data, but not the information they need. And that was probably the most resounding thing that we heard, that, some of that information was irrelevant, not complete. And so trying to focus down on how can we provide a single source of truth is one of the things that we heard from practitioners is, hey, if there's a place I can go and get notifications that they need a single source of truth, because some of the notifications they get, when they get it from that, they'll can get 3 notifications from a health plan, ENS, and the hospital, and none of them really match exactly. So it's interesting. And so it's like, if we can have a single source of truth that also provided us with the medication history and discharge summary, so that I know what medications were changed at the hospital, so I can do that medication reconciliation with my patient, and I know exactly what occurred with my patient, especially primary care providers. That was a huge thing. From some of the specialty providers, we did hear that they get overloaded with information that's not relevant. Like if I'm a gynecologist, and my patient goes somewhere for or goes into the hospital for a heart procedure, that's not something that I really need to know. That was a specific example. So you're on camera, that. But, if you're an obstetrician, you would want to know that, of course, but, some folks were like, it's just a little too much information, for what they're doing. Yes.
Pam, is there any, because I think that information overload is a big issue. And like what we talked about with the transfer form, could there be any effort to try to synthesize what is needed, and then if it runs through the HIE, then they get what they need without all this other stuff, but they've got the ability, if they wanted to see, somebody was recently at the hospital, did they control into that? Is that possible, or does that take getting their feedback on what should be included in the HIE? Like, is all this other stuff that they're getting is just coming outside the HIE? Is that it?
It's coming from both, and some of it is, it's coming through the encounter notification service. It's coming in, and probably some of the health plans are getting it from the encounter notification service, but they're doing something on their end and then sending it. And then some are, say they're getting a fax from the hospital or an e-fax from the hospital. They're getting a secure email from the health plan, and then they're getting however they've set up the encounter notification service.
Some of them have access directly to the EMRs.
Yeah, that's true. Some providers actually have access to the EMRs, but typically what they were referring to as far as overload was the actual alerts or notifications. And the fact that they didn't have all of the info, if there was a way, and potentially Kim, yes, I mean, that's part of looking at, right, when we do our invitation to negotiate, that could definitely be something that we look at. And of course, with retention of data, there's an opportunity to clean the data a little bit better. So.
Pam, I have a question.
Yes.
Pep, go ahead, please.
Yeah, thanks, Pam. I thought the survey was actually worded very well and specific, and I thought there was a question later that maybe how can the current ENS or vendor help? So was their point that they don't have a way to filter? Or were they looking for the current vendor to help filter some of that? Did you get a take on how they responded? Because I agree, everybody shook their head when they said they're getting too much information, but some filtering and some vendor assistance probably could help.
Right. And I think that's what I was just, that was kind of goes to Kim's question tab is, what can be done to help with that? And I think that was really kind of the takeaway for us as the agency is we need to make sure that we have a way to do that and be able to provide solutions in the vendor that's selected needs to be able to provide solutions that assist with that and assist providers with that. One more slide. Unless you want to ask a question.
No, I'm gonna go.
I do
back.
have a hand raised.
So,
Yeah,
This
Peter
is-
has a question. Peter, yes.
I just want to double down on that. I think that there's certain data flows that are going to be handled through the HIE, right? And there, whatever we're doing to make sure that we're delivering the most effective data flow as a whole, meaning that we're not sending the same data 3 times or whatever, is reasonable. But much of the complaint here is that there's multiple sources. And I'm believing strongly that we need to emphasize that the responsibility for filtering multiple sources of data isn't on the HIE side. That's going to sit very, very strongly within the provider EMR function and process. It's sort of like, if I have 4 different systems in my home that is going to notify me of smoke, that's, I'm not asking each individual source of notification to filter out its notification based on what somebody else might be notifying me. It's my responsibility of how I'm handling that event notification. I think it's fairly important for us to be clear about where our scope of contribution is versus, what the provider's tool set needs to be able to accomplish for them.
That's a very valid point, Peter. We really don't have control over what gets sent to them. The only main takeaway is really that their input, that they have a kind of source of truth. And if the HIE could be that, if the solution could be that, then they have a place to go, that they know that they can get, the information that they need.
Well, I think part of what I'm saying is that I don't think that the state HIE can ever be a comprehensive source of truth, especially as healthcare is becoming more and more holistic. There are many elements of a whole picture that are coming from overlapping sources, and so I'm going to be very concerned about the idea that the state or anybody else is going to try to own being the source of truth. I don't mind if they're saying it's a source of truth, it's a limited source of truth. But again, I just think we need to be careful what we aspire to.
I'll make a comment to that, and by the way, once Pam is done with the listening session feedback, we're gonna swing right back to the beginning, and we're gonna get member feedback. So from the HIECC, so because I think some of you would have previous slides, more comments to that. So we want to go back. We'll go back through just to see if we got any questions on the listening session for each slide.
We're going directly in. Do you want to go into the topics of partition data?
Yeah, well, after you finish this, but one thing I will say to this, Peter, you're exactly right. And one of the issues of the data overload is just essentially the way it's set up. No fault to anyone, is that the subscriber submits a patient panel, and so the electronic notification service right now is just sniffing for any alert that happens for that patient, whether it's gynecological or it doesn't matter. They're not sniffing. They're just like arrived, departed, and they're just feeding it. So to sort that, so that's why the data overload, and it's not being able to, because they're just sniffing for the patient that is pertinent to the subscriber. That's the way it's set up now. We can think about how that could be filtered additionally, but that's why the overload's happening. Because they're getting it as from the payer or from the health system, because they got agreements too for those patient panels as well. Okay, Pam.
Okay. The last thing, just
Mary has a question. Mary, I see that your hands are up. Please go ahead and ask your question.
Marie.
Mary.
Yeah, that's okay. I was just going to comment on some of the feedback that you were giving, Pam, but I mean, I guess based on Craig's comment, do you want me to just wait until you're done with the slide?
Uh, Marie, go ahead.
Okay. I just wanted to make a couple clarifications and comment on the issue of overload, because I totally agree that, there's overload and there's volume and not good clinical content. But a couple things. We have had the Florida ENS, Florida HIE ENS service for a while, and I think that was working pretty well. When things got worse, in my opinion, is when the CMS conditions of participation requirement came, from the federal government, saying that basically you have to ask the patient who they want to notify of that admission. And so in order to meet that requirement, hospital systems are trying to send those notifications from their EMR system. They're trying to send it through the HIEs. They're trying to send it in any way they can in order to comply with that regulation. And unfortunately, both the ENS as well as the CMS COP messages really are not built for clinical content because they're based off of an ADT message. So at best, you're going to get an admitting diagnosis, discharge diagnosis, or a chief complaint. But these messages are never going to have a discharge summary, a medication history, lab results, imaging results, or anything like that. So there's always going to be lack of clinical content with these encounter notifications, regardless of where they're coming from. So I just want to make sure like we're not confusing things, in order to really get good clinical content, like a summary of care, after an admission or ED visit, for example, you're going to have to connect to that EMR system at that health system and be able to, pull that summary of care. These ENS messages are not going to give you the clinical content that you need.
And that is accurate. We have seen that there potentially could be like the Archer service that we offer. Marie here in Florida does provide that discharge summary. So it attaches to the encounter notification and goes to the eHealth exchange. So if that facility where the encounter occurred is connected to one of the national networks, it would go out, pull that discharge summary and pull it in. So there are additional services that can be offered that would provide that, but not the basic service. You are correct.
Yeah, I think the challenge that I have experienced with that, Pam, is, providers don't always get the discharge summaries, completed right away. There is quite a lag in when they complete those. So I think that's another challenge, out of our control, but certainly playing into this, that when those CCDs are triggered to go out, there's not always a discharge summary.
Yeah, that's going to always be an issue. You're correct.
We have focused on adjusting when we query out for those to make sure most robust.
Go ahead and Brian, do you
sorry.
want Brian has.
Hey, Murray, how are you? Brian Smart. Yeah, so we actually are constantly looking for that Archer solution to make sure we're querying out at the right time to pull down the most robust documents, because we definitely understand what you're saying. A lot of times you query out an hour after discharge and only get, a small portion of the full visit summary. So we're always looking at the algorithm and the logic to make sure that we query out for Advent or Orlando or Memorial, that we're querying out the right time to make sure we get the most robust documents, because all the workflows will be different. But totally hear what you're saying.
And by that, Brian, are you is there some intelligence behind the scenes that lets you know when that discharge summary has been filed, and then that's when you query? Or are you just kind of doing the best guesstimate of, 6 hours is a good time after discharge, or 24 hours after discharge?
We basically take a look at, we use AI logic to determine when's the best time. And then based off the results and the amount of data feedback, we figure out, can we move that up? Can we move it back? And then we also interact with some of the facilities directly to ask them This is when we typically do that. Are you typically closing out your visit summaries post-discharge around this time frame? And we'll make sure that we review and analyze that to make sure it's valid. But yeah, we're constantly working though, and it is a moving target because when hospitals get inundated with more patients getting discharged over a certain time, they're a little slower on those, and that's something we have to look to adjust as well. So.
Yeah. Okay. So it sounds like it's a set time. Yeah, I think that varies a lot also, you know, if you have a resident that doesn't know before the attending and so forth. But I appreciate the efforts to try to keep tweaking that. Thanks, Brian.
Yeah. Ankush Bansal have a question. Please ask your question.
Yeah, just for information, most hospital staff rules, not universally, but most require discharge summaries within 72 hours after discharge. So that may be one, you may want to use that as a rough estimate, 72 hours.
Thank you. Final slide on this. Just some general input from folks. It was that it was important to maintain a reasonable cost, responsible cost for service. And I don't know why, I think it was supposed to be reasonable. I don't know why I typed responsible, but reasonable cost for service. That was an overall concern. The importance of the agency, this was very shocking to me, the importance of the agency governing the program to ensure transparency, cost and infrastructure, and to support public health activities. Integration of, or there was a general interest in integration of encounter data into electronic health record system, and a desire for FIGS for us to take a look at how can we do more of that. And of course, again, too much data and too little information from providers. So those were just kind of some general inputs that we got. That's all, Mr. Chair.
Well, we were talking a little bit ago, Pam reminded me that I had not followed directions, and if I would have known that the next slide is actually what we're going to move into, the retention of data and discussion. So, does everybody see that?
Can you want me to take slides? Let me stop sharing.
Yes, we can see it.
Into the next. That one. Next one.
This one.
Okay, so this is the interactive portion, and you had a chance to listen to the input from the listening sessions, and so I'd like to go around the table and talk a little bit about the various topics. And so the four are going to be retention of data, interstate exchange of data, consent policy, and I guess it's three, but I feel like there's one more. And maybe we'll talk a little bit about future solutions, maybe if we get to that. But so retention of data, here's the questions I'll pose to you is what, if any, are technical or operational considerations for providers does the agency need to consider if a decision is made to move from the current ENS model that does not retain data and is Florida-centric to a model that does retain data and would move endpoints to the vendor's network platform? That's a long question. If you'd like me to repeat it or turn it into Craig's version, which would be currently, it's Florida-centric model, data resides in Florida, and then we move versus moving into a vendor's platform model where It's outside of the Florida-centric model. Does everybody follow that? And do we have questions?
We don't.
So by that, do you mean? Because I guess I took the retention of data. Right now, it's not retained. Is that right? So if you wanted to go find when somebody was, that they said, oh, I was admitted to the hospital or I was discharged, like they can't really go back and find that now. And so moving to something where that you could go back to find when were they, discharged, but I think that it's limited to, yeah, that they were there, but nothing about that state. Is that correct? So it seems it would be helpful, if I'm understanding this correctly, that for them to be able to look for some retention of data to find out what has been happening, but it's got to be more that, yeah, that they were in the hospital, or they were, I guess, transferred here. It needs to be more than that, in my opinion. So retained, and it's got to be more than ADT.
And it's got to be more than ADT, okay? Does anybody have any other?
Yeah, we have two questions.
Okay.
And Coach, please go ahead and ask your question.
Thanks. I actually have two questions. One, I agree with the previous speaker that it would be good to retain that data. ADT data would be very helpful, especially if it's Florida centric. So let's say I'm in South Florida and somebody's visiting family up in the Panhandle. At least I can get that data that they were admitted. But it would be nice if, for example, they were admitted, what the dates of the hospitalization were, and at least what the primary or the discharge diagnosis was. That would be helpful. The second question is, okay, if it goes to the vendors, so I'm assuming that means beyond Florida, who is responsible for the data security? Because that concerns me a lot then.
So the data security would be the responsibility of the vendor. And that's why we did get a lot of feedback on requiring a vendor to have high trust certification, which is the highest, basically, security certification that you can get for maintaining data. Our current vendor, Audacious Inquiry Point Click Care, is high trust certified. That just kind of, that was one of the things that we got from a lot of the CIOs at facilities was, when looking at retention of data, there wasn't really additional concern as long as it was, the vendor was high trust certified.
Okay, so the second part of that question then is, how do we ensure that it's not going to be used for other purposes, let's say marketing or data mining, because that's a concern with a lot of, not just EMR vendors, but a lot of different industries within healthcare, because the public will be quite concerned about that. I would, if I am, and a lot of other people are, I would imagine they would be too.
So that is currently the way we handle that is so the agency has an agreement with the vendor. And so it's handled through that, but also through the encounter notification service agreement. So the providers that agree to share data have signed an agreement with the vendor, as well as folks that are receiving the data have signed that agreement, and that agreement includes limitations on the utilization of that data. So we would want to definitely maintain a requirement in the agency's contract with the vendor, but also in the agreements that are held between the providers in Florida and that vendor. And the agency is responsible for the governance of the program, and that's one of the things that we did here, that they would, folks wanted the agencies to still be involved in developing of those agreements and that type of thing.
Okay, thank you.
Yeah, Tab had a question. Tab, please ask your question.
Yeah, thank you. And I agree with previous members' comments and concerns. And Mr. Chair, your question was on what operational impact should the agency need to consider for the extension? And I think that goes based on the use case and a little different from the sources and then the subscribers. Speaking as a payer and a subscriber, we as subscribers have to provide our member panel, right? So if some of those previous security questions aren't addressed, concerns aren't addressed appropriately, then the member's gonna say, Florida Blue, was that our payer, was that your giving my information out there, based on the panel, or was it in some other transmission? So not sure that's an operational impact. It's just a thing to consider. I think all the comments on the security are very relevant though.
Okay, great feedback. Just further that, what would be another use case for the retention of data? Why the requirement of retention of data?
Frequent flyers.
Okay. Frequent
Snowbirds.
flyers, identifying frequent flyers, okay.
Snowbirds. Going back and forth between New York and Florida.
Well,
Yeah, so snowbirds was the comment. People are moving, but that's around the state of Florida. But if people were in Minnesota 8 months out of the year and they came down to Florida for 3 or 4 months, that historical encounter information could be relayed over. I think another thing for folks to think about.
Let me ask a question on it. Would that be more about cross-state sharing than it would be about data retention?
It'd be a little of both, but you're right, probably more cross data sharing,
Okay.
but also the ability of, like to Tab's point about health plan, maybe they enroll another 30,000 members in a county because they expanded their Medicare or Medicaid. They could immediately obtain historical information on those patients to see, have they had a lot of encounters over the last month? Maybe they're high utilizer, maybe they have asthma or COPD, and we need to get them in a specialized program from day one of enrollment versus finding out 6-8 months later, having to do calls and figuring out what their historical encounter history looks like. So it also provides from a health plan, from a hospital standpoint, when that patient walks through the doors, if they maybe take advantage of the EDO solution, they can immediately see this patient walks through their doors and they get an immediate pump of data to say that this patient's been in the hospital 7 times in the last month across the street, not your hospital, but across the street. And they can now take that data and see it. And a lot of that data, you're right, is state specific. But also if you think someone comes from another place into Florida and they moved here, and they're living here full time, but they haven't been to the ER since they've arrived. But maybe in another state, they were in the ER 10 or 12 times in the last year. That's something that I think might be able to help the hospitals to better treat that patient in real time, not find out 3 or 4 days later while they're in the care.
I just want to, Tab just typed in other patterns. So just to point that out.
Yeah, I mean, Tab, to your point, historical information also allows for better analytics, better determination on trending, things that maybe we can help the state with, or information like that can help the state to determine where funding might need to go for additional things that should be set up to help.
Yeah, I would say 2 more cases are, and this is within Florida, are people that internally relocate within Florida. So let's say somebody moves from Boca up to the Villages. At least now the new physician in the Villages will know, okay, this person's been admitted these many times to West Boca as well as Bethesda and wherever. And then the other thing is, for those people that may change primary care physicians because their insurance changes, especially this time of year during open enrollment. They may change insurance and now their primary care physician is not part of that plan. And so they have to change primary care physician. At least that new primary care physician knows, okay, this person's been admitted for these things on these times for these diagnoses.
You know, it also seems like that retaining data, it needs to be more than just the admit discharge, but more like with what we were talking about earlier with the 3008. If there's a way for them to see why they were there, were they on oxygen, any of that historical data And maybe that is in the CCD, but that ability to know why, what has happened in the past, I think would help in the treatment, more efficient and effective treatment of patients. Now, how do you distill that down so you're not just giving them this massive data? I don't know, but we know that knowing the medication history, any of the other issues that were identified, they're on anticoagulants, all of that type of stuff, I think would be a huge help. But whether that can be done within, you know, the system is another question. But I think that ability to retain it and for somebody to see a quick glance at what's happened with that patient in the past, I think it would be beneficial from a quality, you know, efficiency, cost effective treatment, all of that.
I think the last thing I'll jump in here and say is regarding patient matching. Historical information retained allows for better patient matching with any NPI you have. So the more data you have, the better patient matching and more correct patient matching. Okay.
Yeah, we have a comment from Peter. I guess the only thing I want to be intentional about is what data should the HIE be responsible to manage. AGT history is one thing. CCD and NORS history at a state level is a very different thing and raises very different sets of questions. The advantage of ADT driving ENS is that it can inform us of what providers' local HIEs we may need to interact with to appropriately gather data.
Can Peter just unmute himself and share his comments?
Yeah, Peter, can you unmute yourself and share your comments, please?
Sure. You know, I think the big issue is to make sure we're understanding the role of the state HIE versus the regional HIEs versus other tools that are starting to be used to aggregate data. So, you know, so what's part of what's being expressed is where can I get sort of a universal history of medications or a universal history of ADTs and so forth. And I think we need to determine whether the state HIE's role is going to be sort of repository / directory of that data, or whether it's an enabler of sort of the links. Is it simply a directory that's pointing people to the local HIEs and so forth? That's true both at a national level and at a regional level, that there's mechanisms for data exchange. And the issue for us is, you know, what data are we wanting to maintain for the short term at the state HIE level? What data are we wanting to maintain longer term at the state HIE level, as opposed to leveraging you know, other platforms, including our local HIEs and so forth, where there's a lot more sort of community participation in what the rules of engagement are. So again, I think this goes back to the issue of thinking carefully about what our stewardship is. Is it to be repository or is it to be directory?
Has there been consideration for moving to a Florida-wide CDR or clinical data repository model?
I mean, that's very aggressive, right? Compared to the approach we've taken in the past. And I'm not saying it's wrong. I'm just saying there's a huge infrastructure out there around regional HIE that we're enabling. And so moving to state level CDR, it's a huge discussion.
Right, and I think we moved away from that in Florida when we, I guess was it 2017? Because we did try to develop, you know, a hub here in Florida initially back in 2011. About 2017, we made the decision to get out of the way of data exchange and allow folks to connect through those national exchanges that are out there. Especially with the move right now with TEFCA, the QHINs, and folks being able to utilize their regional health information exchange to connect to those national exchanges. And we're seeing growing success with connectivity of providers through that. And then we are also looking at and seeing, our ability utilizing the encounter notification service as the way that we have it established right now, and expanding that to provide, information or limited information like those discharge summaries through Archer, utilizing that encounter notification service for folks that need that limited data set as well. So I don't, there wasn't any intent, or the agency has not looked at moving back, especially with the way things are going nationally with HIECC. I don't think that we would want to step back into that role, because that would be significant dollars or infrastructure dollars that we do not have. If we were going to do that, we would have needed to done that back in 2011. So that's not a direction that we are looking to move into.
Thank you.
Was there somebody else that? I
Yes.
thought Bruce had a comment.
Yeah, Bruce has comments, and Diane has comments too.
Diane's.
Bruce, joining for Dennis from DOH. Yes,
Okay.
Bruce has a comment.
I was just saying that as far as keeping the ENS data for historical purposes, certainly we're interested, in that border state data in Georgia and Alabama. That's a long border, and as the population centers increasing on that border, then getting that encounter data would be useful, especially some historical perspective for patients who are moving to and fro.
That really kind of goes to the data, the interstate data.
Okay. Does anybody have any retention of data? And just to be clear, let's make sure that when we're talking about, this is a great question or comment. This is purely about encounter notification. This discussion, not to just, we all want clinical. Yes. For this discussion, we want to really hone in on the electronic notification service. And the data, retaining the data. Now, so the question would be, is this Florida, what are the pros and cons of a Florida-centric? Keeping it a Florida-centric, or on the next vendor, allowing it to be part of their vendor platform? Same. I just asked something that limited me like silly.
Well,
Gotta stay wrong.
no, I guess retaining the data, I think that's correct. So would we want to, if we retain the data, would we want to retain just retain it for here in Florida? Or would we be okay if a vendor had a model that integrated that data with other state data? Would there be an issue with that? Which is a little bit different than saying if we retained it at a national level, because, everything's cloud-based, and so everything's retained at a national level. But if it's housed with a vendor that houses it with other state data.
Ankush, I see that you have a comment. Would you please make your comments? Unmute yourself.
Yeah, so one of the reasons that I like the retention of the data is if I'm working in a hospital that uses, let's say, Epic, and the patient has previously gone to a hospital down the street or across town that uses Cerner, I can't get that Cerner data because of data blocking and because of two different companies. I have to call that hospital, and generally, even to this day, they will fax it to me. If both of them use Epic, let's say, then I will see a notification that they have other records, and then I can request electronically that they release that so I can see it. So having something, for example, like this HIE with the ADT data, at least I know that they've been admitted previously, or they've gotten treatment for something previously and what the diagnoses were and when that happened. This was something that the ONC was to take care of in the last few decades, but still has not been resolved.
These are all great comments. Sorry, we're taking notes. It's being a little, I'm helping Pam take the notes so we can make get an accurate reflection of what the comments are. And I hate to, I don't want to stay on retention of data, but it is something that really needs to be thought through. And why the retention of data, for how long, who's using the retention of data, the subscriber. So when the subscriber says that they get the last 2 years prior to the subscription, I mean, these need to be very clear. So we're not hand picking. If you're looking for frequent flyers, and we never want to put the position of the hospital as the provider, the people who are providing the ADT data, at either a disadvantage or somewhere where they feel like the participation is what it's meant to be. And so the storage of data matters. On that front.
Can I go back and clarify what I've heard, I think I've heard so far? Is that I haven't really heard anything about opposed to the retention of data. Concerns are similar to what we heard from participants, and that is security. So making sure that the vendor is HIECC certified and that we have provisions, and also the security or measures within our contracts around appropriate use of the data, so that the data is not mined and inappropriately sold. We did not talk about length of time, so that's something we would like to get input on. And there was, varying conversation around, what we want to retain. But it was clear that it was okay, that folks seemed to be okay with the thought of at least retaining that ADT data, having in working to get that discharge diagnosis and as much information as we could to help support the providers and other folks that are would be utilizing that data. Right. So I think there was a couple of things that I would like to get input on. We were talking about whether we should retain just our state data or if it would be okay to mix with other states. That may kind of flow into that cross-state data exchange conversation, which might flow into that patient consent. And then also length of time. Right now, the addendum that the advisory council did was to allow just a minimum of 1 year, retaining the data for a minimum of 1 year, and then allow flexibility for doing away with the data after that time. So the data sources would hold more flexibility.
Do you know what other states do in terms of retaining and for how long? Because it seems like that there would be some type of a standard. There's no.
It varies. Some and how systems are rolled out varies in state to state, right? Like so, some even with our current vendor, how they have rolled out, some of them work with the state HIE. Some of them work with professional associations and they work directly with the providers, not necessarily the state HIE. So it varies from state to state. And so the length of time varies. Some there's no length of time provisions, and then others have like 2-year provisions, something like that. The current vendor, and Brian can correct me if I'm wrong, has really said 2 years really is enough. And even 1 year would be okay for the data retention. Some of the input that we got from folks was there really wasn't a concern with time, because once the risk is there, the risk doesn't increase by the length of time retained. The risk is there just initially. So as long as you have that high trust certification, there wasn't as much of a concern. So.
Yeah, and to Pam's point, the Point Click Care National Network platform, all the states, Arizona, California, Colorado, New York, I mean, I can go Ohio, I can go on, all have similar 1 to 2 year data retention policies. And basically, given that they have an opportunity either after a year to go in and request and say that data removed, or after 2 years, it's typically automatically removed out of the system. So, but all the states on the national network operate that same sort of data retention and interstate exchange.
So after a year, they have to request it to be removed, but 2 years, it's an automatic sweep.
That's correct. So it's, you know, once that ADT is older than 2 years, it automatically removes, but then we do request that the data sender make that request to do it. We have a robust data analytics and, you know, data integrity, data quality team at Point Click Care that does typically quarterly check-ins with our data senders. So that's the opportunity for them to kind of say, hey, we're approaching a year. We want to go through and update that. And then, of course, we also are the full system is HIECC certified. So, yeah.
Yeah, Ted has a question.
Yeah, go ahead.
Thank you. Actually, it was I was going to ask you, Pam, but Brian just said it. And I guess it would be for Brian. Does PCC identified which use cases might be better if you had longer than 1 year? Because I heard Pam say that PCC advised that 2 years would be ideal, but could do it with 1 year. But I would assume there's going to be some use cases that might not work as well.
Tab, I don't think there's use cases that don't work as well. I think the main thing is historical insights, data analytics, things like that you wouldn't have as robust data. Like if we were retaining data for 2 years and providing that information back to the state, having a picture of 2 years versus a year might change things. I mean, you look at when COVID hit, you know, the year before that data looked really good, but then with COVID. So I think if you have a longer amount of data from a analytics and insight standpoint, that helps. The matching element, that's another thing that might help if you have it over 2 years, because if you think a patient may change their address and update their health plan or provider, but they may not go in the hospital for a year and a half. So that hospital maybe has an outdated or old record and they don't ask the patient to update it. So that's something to think about as well. But from benefits, you know, risk identification, historical insights, emerging risks to the state, the snowbird information can be helpful. You know, high flyers, risk score, all this stuff can be surfaced with the retention of that data.
Okay. You know, Brian just brought up a legal work group problem. If you are retention of data, and now you're doing analytics on it, and the vendor wants to sell the data to the people who would like that, that's a whole other animal. We really need to think that through. Right now, we're passing ADT notifications on a patient panel. Now, by the ability to retain it, then you can do analytics, and then analytics changes the subscriber. That's a different buyer. And so what does that mean with opt in, opt out, consent? Are we even allowed to do that? Why are we doing that? And I bring that up just so we can think about it. I'm not saying, I'm not putting any opinion on it. I'm just saying that that's part of retention of data and why you'd want to do it. I mean, there are use cases in historical data, but if you're wiping out after a year or two, then the frequent flyers, I don't know if you get that in 1 year or two. So there's the real use case is the analytics of retention. That's where that's something for to consider. I'll take comments on that. If not, we'll move on to the next item.
Yeah, my only comment on that would be, we obviously, under the contract with HIECC, do not reuse, do not sell data. The entire point of care organization does not reuse or sell data. Typically, what we do with the data is provided to the state for their use cases. So Department of Health, state Medicaid agency would be able to take advantage of that historical information. Typically, PHI is scrubbed out, but it's reporting, it's understanding what are the utilization like, start with different counties that have higher or less, maybe triggers off diagnosis codes, like what Dr. Kogel's doing with the Medicaid. So there's a lot of capabilities that can be provided for retaining that data. But the point of care, similar with audacious inquiry, do not sell, do not reuse, do not repurpose that data for any sort of profit within our organization. So just to clarify that, but I definitely understand that's a concern that we have to be addressed through a response through a vendor to make sure it's written out cleanly that we do not do that. We do not have authorization.
The other thing I wanted to mention is, you know, Pam, you mentioned that hospitals are moving to an opt-out model. And with that model, you know, patients sometimes don't realize that their data is getting sent and shared with the HIEs, even though it's like in the notice of privacy practices, for example, or the consent forms. But when a patient comes to us and says, I want to opt out, or I want you to stop sharing my information, sometimes for them, from that point forward, is not good enough. They want us to go back and, you know, remove everything that has been shared with any HIEs. So I've talked to Brian about this, but for the group's benefit, you know, I think it would be important, if we're retaining data for a 1 or 2 year period, that if the patient says, I want my data deleted from the HIE, that the HIE, the vendor's able to do that.
As you right now, the way that process works is if someone contacts us, meaning the HIE, whether it's the vendor or the agency, to say that they no longer provide consent for their data to be shared, they have to go to each of their providers that they have consented to share their data and remove that consent, because we do not hold that data locally. So they would have to go to each and every one of their providers that they have authorized to have access to that data to remove that consent. And so there is a lot of work on the patient side is related to consent with the current model. And if you do retain the data, I mean, that could be part of our requirement from a vendor as well, is they have to be able to work with the patient to remove consent if they so desire, if there is retention. Do we have like is there input on an actual time frame? Is the 2 years, is that, I mean, is there any other than just around the security, just is that 2 year time frame okay with everybody?
Seems logical.
So just to go back, what I've heard is there wouldn't be opposition to retention of data. 2 years is probably, the people are okay with 2 years, with the ability to do it earlier if they so desire, but at least 1 year. Ensuring that the data could not be reused or sold, that the vendor could not do that, and that there is security provisions around that. So, I mean,
In-house,
it's-
over 40.
in-house in the, well, that was input from other folks, not this group, but, house in the lower 48 was input that we got from other users, so.
A
Everybody
2-year math
needs-
is definitely reasonable.
2 years with the ability for someone to choose after a year. Is that
That's,
kind of proper?
that's a great option.
Then as part of that we did not necessarily get an answer on is a Florida-centric model versus a network-centric, or vendor network-centric.
I think because the amount of snowbirds that we have in our state, that I think a network-centric model would be better. That's my recommendation.
Kim Tendrich.
Okay,
Again, the Florida, Georgia data would be important to us.
That might go into our next conversation, which would be the prostate.
well, yeah, that's,
So
or do you get some?
My question's really more, what's the, like, if we want to get all the patients from across state lines, right? And so would that have to be, like, I'm confused about the vendor specific, like, would it only be those with whatever the vendor selected that we could get access to? Or is there a way?
So,
Well, no, I think.
well, so looking at it from our current vendor perspective, if the solution that our current vendor has is connectivity to the providers that are already associated with that particular vendor. There is, and we have looked previously at the ability to share data across state lines, and are we moving into?
Yeah.
Okay. But so we have looked into that previously, and there is, a organization called, Civitas. It used to be HIECC, and that supports interstate exchange of ADT data, utilizing a patient-centered data home model. But with that is, it's so the ADT exchange, utilizing that model, you have to comply with the requirements of the agreement, right? So there's an agreement between HIEs and states. And our barrier here in Florida goes back to the behavioral health provision of law that requires explicit consent to receive the data.
I think, Pam, and the pros and cons are, this is just an opinion, I don't know. Pros and cons of a vendor-centric versus Florida, and I would say that vendor-centric, and again, it talks about you're leveraging some infrastructure that is used in other states. I don't necessarily mean that's commingling of data, it's just leveraging other infrastructure. To disembark from that is another challenge to be thought through if you use the vendor network. Also, I would say that having worked with national exchanges and so forth, the patient overlap is not as robust as we may think. In other words, you think you're going to get all this great clinical data from all the snowbirds, but that requires that hospital, that wherever they're from, to be on all those networks and have all that set up. It may or may not be the value proposition that would force a vendor into if he doesn't have that, or he or she, or the company, I should say, the company doesn't have that network, or does, whether or not it's the true value proposition that we're looking for. That would be the con pro on that side. And I think on of keeping it from a Florida, Florida's a unique state. Let's not forget that. For those who live here, we are Florida, and Florida's Florida. And Florida wants to be Florida and not something, and politics change, but it's pretty much the same theme all the time. And I just want to remind everybody, like, I know we're healthcare providers or in the industry to provide better healthcare to Florida citizens and those who visit. Florida wants to control Florida and its citizens and not have to worry about the network of different, and that attitude is very, it's prevalent across multiple, and I'm not being political, I think that's the natural feeling of Florida folks. So being able to control Florida's data would be an important thing to consider. That's the pros of the Florida. I just bring that up as why we were asking that question. Those were the discussion points. Okay, hearing no feedback on that. Interstate exchange of data. Okay, Pam. You're in charge. Hopefully he is. What technical and operational considerations does the agency need to consider when looking at interstate sharing of ADT data? Before I do that, Bruce, you made a comment, Kim has made a comment on that. Maybe the Department of Health would be the first one to open it up for interstate exchange of data.
Well, certainly for public health purposes, we're interested in what's going on in Alabama and Georgia, among those border states for us, as far as clinical visits and syndromic surveillance, that sort of thing. And then, in our large population areas, certainly the snowbird data would be of interest as well. So, that would be our primary focus there, is getting that encounter information.
I agree with you, Bruce.
Okay.
This is Maria. I agree that it's important. I mean, we have, children that in North Florida, we don't have a hospital per se, so they might go to Children's Healthcare of Atlanta, for example, or, if it's a child with a lot of complex medical conditions that the family has been struggling to get answers to, they might end up going to the Mayo Clinic in Minnesota or, Johns Hopkins in Maryland. So I feel like from my perspective, as a health system, it is important.
I agree. I think it's really important, that ability to exchange data interstate, however you want to call it, because I think for that just to improve care, and with so many visitors that are coming to the state, that ability to be able to, if they show up in the emergency room, that ability to have a good idea of what's going on versus, one of our residents being treated in another state, we want them, to their information to be readily available.
All true. All true, but we're talking about electronic notifications.
Yeah, so Peter is saying he's supportive for countrywide exchange. Did I say it right, Peter?
Correct. And by the way, I don't think that having ADT is the same as event notification. I mean, as ENS. I think it's simply really more at the level of query.
Sir, do you mind providing a little bit more clarification on that comment?
Okay. I'm believing that ADT, allowing query of ADT based on presentation has huge benefit. I am not believing that we need to do ENS of ADT movement across the country.
Well, what he's saying is he does not Well, I shouldn't tell you what you're saying. You said it pretty good. Maybe further clarify on the value proposition or non-value proposition of electronic notifications across state lines versus the ADT, which is even essentially the same. But go ahead. I don't want to put words in your mouth. Could you maybe clarify on the value or non-value proposition of that?
I mean, there may be other clarifications that others would want to make beyond my statement. My statement is simply that a repository of ADT countrywide is relevant. ENS across state lines may be very relevant, but I'm not believing that ENS countrywide is relevant. But I am believing that the directory that allows on demand, people are trying to identify frequent flyer, identify other things that if that your ability to query. Now, I do agree with the comment that's made after me that across the board, everything we're doing with ADT and ENS is available through other models that have their own value equation, their own service sets, and what we're doing is sort of the first level. I'm going to call it directory level of that. Maybe that distinction isn't particularly meaningful within a product. I may have a fundamental misapprehension of how we're delivering service. But we were just having the discussion: are we going to maintain 2 years of ADT history or 1 year of ADT history? That's a different kind of statement than are we going to do event notification. And I'm simply saying that as we're talking about interstate exchange of ADT data, that may still have a relevance for us as a historical reference without it necessarily driving ENS. The ENS function could be relevant, and I'll let others who are making the case for cross, border state to make the case that, well, they need ENS too for that environment. I just was expansive. ADT, for me, I do believe that Florida, as much as anybody, I mean, just simply visiting into Orlando, comes from all over the country, and so I wouldn't want to just say cross-border. I'm saying nationwide ADT is relevant. Again, Diana's making the comment, well, maybe just use National Health Exchange for that. I'm simply trying to keep us in, if our core functionality that we're supporting is ADT and ENS, then I'm saying do this for ADT, ENS is narrower.
What's the difference between ADT and ENS?
Well, as I mentioned earlier, when Kim asked about the connectivity between states and the ability to share encounter data, which is an admit, discharge, or transfer data, right? Between states, there is, like I said, the CIVITAS Patient Center Data Home model. There is also there are also vendor models that allow just for connectivity or sharing of that data between their data sets within states, right? So there are varying models. So I'm trying to pull out, Peter, what, if that's what you're referring to, is it the importance of being able to share between HIEs and other states that have that ADT model. It's not necessarily an encounter notification service. It's not called that. It's an ADT model where they're sharing encounter data, right, for a patient with relevant providers in other states where there is a commonality with that patient. Is that what you're saying?
I think so. I'm not trying to expand what we do. I'm acknowledging that there's additional scope and that scope isn't necessarily just Florida, Georgia. It needs to be broader than that because of the nature of Florida as a national destination, not just snowbirds.
Okay.
consumers, whatever. But I'm trying to say it in a way that doesn't it sort of expand our, we just talked earlier about people getting over notified. We don't want event notification going to people from 50 states around people. We're more interested in how are we making sure that if someone appears at a particular setting, that setting is well aware, that they have a place to go to that says you better go link to the national networks because we're aware that there is ADT activity elsewhere and counter activity elsewhere. Now, again, I'm trying to match this to the best of my ability to what the Florida HIE does already and just modify scope of it. I'm not trying to add services.
Peter, I think ENS, in my mind, is the trigger for the PCP to know that something happened to the patient. So, I don't know that they have another good way of knowing, oh, let me go get that ADT data if they don't have that ENS message come in proactively.
Well, I guess, and this would be interesting. In my situation, I remember I represent long-term post-acute care. We rarely have an interest outbound and say, oh, a patient that we have served in our environment just checked in somewhere in Alaska. What our interest is when a patient presents to us is we want to know what their history is, not just what hospital presented them to us, but we want to know their history. Now, part of that we're going to get through other networks, we're participating in a variety of networks, but the state is already holding. We just had the whole discussion about how long do we want to maintain ADT history and what the benefit of maintaining ADT history. So I was trying to work off of that model. Now, whether that's the most relevant way to think about it or not, I'll stand corrected by the rest of the group. But that's what I was trying to do, was simply to limit this discussion to scoping of a service we already deliver, and for me to say that this may not be a service that is based on us knowing where that patient is checking in elsewhere across the country. It may be more along the lines of, as they present to us, how do we get appropriate access? Others may have very different use cases.
Yeah, I definitely see your lens, where you're coming from with long-term care. I think it's different for us as a health system, being the medical home or the pediatrician for a child. And then if they go, I don't know, say on a trip to New Orleans and, they have an acute event and they end up admitted somewhere, like that's something that us as the pediatrician would want to know that happened. So yeah, different lenses, different use cases.
Just one other thing to throw out from an interstate data exchange standpoint, if you look at the E+ solution, the ability for a patient who in Jacksonville is leaving their home or leaving a hospital to go to someplace in Georgia to get rid of, be away from a hurricane, that interstate exchange can alert their provider, their health plan, their ACO that they've now been admitted to a facility out of state. So just another use case, but I definitely hear what the gentleman was saying in regards to notification fatigue. Understanding that someone, got admitted to Minnesota for, a flu, it may be a little overwhelming, but hopefully the data is valuable.
Peter, we hear you loud and clear, and I think that's just scoping it. I always feel like sometimes we have like to think big, but really we should probably be focusing on and oh, by the way, to get those ADTs from Florida or from Georgia or Alabama, somebody's got to go negotiate that to be part of the system. There's a lot of hospitals that I don't know if that needs to be a requirement that has been put on vendor selection, but it's good to have that discussion. I think the more important part of that question is going the other way. Florida, Florida ADT is going out of the state, not coming in, going out. So if these interstate agreements that are with, if you want to say Minnesota, that's fine. Do it interstate, and those are Florida citizen data, ADT information going outward. You may have a comment on that.
What would be the use case study that? Or it going out?
The same for it coming in. So if somebody lives in Michigan for half of the year and they live in Fort Myers for the other half of the year, their provider in Michigan being able to get those records, or New York and Miami. Those are the two states that have harassed us about wanting to get that data. So that's why I chose to pick on them.
From a patient-centric perspective, like sharing that data, I think is important. If it is, you know, the patient at the center, but I don't know if that ties into the consent policy.
Yeah, I think a commenter on that would be you get what you get. I think that reciprocity really is helpful. You know, I know my in-laws from a personal level. They come down here 4 months out of the year. They go to Fort Myers. They're there. So, but they also live in Maryland for the remaining time. So when they're down here and they see treatment at an ER, their doc in Maryland to get that alert and be aware that they've had some sort of encounter. So I think the doc up there in Maryland is probably more helpful for them than it is down here, but you got to think vice versa. Got a lot of folks coming down here, visiting, and from a hospital standpoint, understanding where they've been and maybe who their care team is, who's their provider, who's their ACO health plan. Maybe I can pick up the phone and get some information about them when they get admitting. I think from a hospital standpoint, it's really helpful to have that interstate exchange.
And I know we're gonna get into the consent piece of this in a minute, because it does really have a definite impact on that model and whether we share out of state or not. But I guess I have a question around should the agency or when we're doing our invitation to negotiate, should we look at, and I know you'll provide additional input, the concept of being able to share with other state HIE systems or with providers in other states that are interested in sharing with us? I'm looking at you, Mr. Chairman.
Well, that's a lot to contemplate. And with that said, we're going to take a break. We are started. Tab, you have a comment you'd like to share?
Yes, thank you. On that last statement from Pam, that actually triggered a thought and a question for clarification. I was thinking this was based on the vendor. So if a vendor's in, let's make it easy, in 3 states, and we'll use the exact same percentage, around 95+% of that state, those 3 states, my thought was that we're only talking about that type of interstate exchange. But Pam, I believe when you said sharing with other state HIEs, I just want clarification. Are we only speaking to what the current vendor footprint would be, if that makes sense?
It does make sense. And actually, I'm asking a little bit broader than that, Tab, not just the current vendor, because we are doing an invitation to negotiate. So we are doing procurement. So I wanted to have a perspective of, how we, really input, is there so, I guess, any concerns or technical operational concerns with one way or another?
Makes sense, and I'll just add another commentary. From a payer perspective, there's the new mandate with payer-to-payer exchange. A little bit different there, but I can understand from the provider facility perspective. Thank you for that clarification.
Any additional comments before we move on to consent?
I was gonna say that I think Diane had posed this question on the chat, but it would be difficult to have this AVT data coming from all the different other HIEs or states or providers unless, in my mind, the vendor already had that footprint and those connections established. I feel like it would be a big lift otherwise.
So what you're saying is the requirement may not be necessary, but it would also, it's a consideration.
Yeah, for example, I'm thinking, Audacious Inquiry, now Point and Click Care, they provide the ENS service across multiple states in the US already. And so they're already getting that AVT data. So I feel like it would be fairly simple, for Florida to get those AVT messages from all the other states that PCC has agreements with. If we were not to go with PCC and not to go with that model, I feel like it would be hard for the Florida HA to establish those connections.
Mr. Chair, am I okay to ask follow-up? Yes, thank you. I'm trying to take on Craig. So Marie, since the connectivity varies from state to state, like the current vendor, so PCC in some states has connectivity to the HIE, in some states they just have connectivity to facilities within that state. What I'm hearing is there really isn't necessarily any distinction in your mind between that connectivity as long as there is connectivity.
Yeah, I think what I'm saying is, we kind of have to think, like Peter's a few times kind of reminded us, like, what's our scope, right? What is our responsibility? And, do we want to go further than, maybe then it's necessary or bite off more than we can chew, so to speak. And I guess that's in my mind applying to this question. If we are going to go with a vendor that doesn't already have those established relationships and legal agreements and connectivity, it's going to be a big lift, I feel, to be able to establish starting to get AVTs from, the other HIs and so forth.
Okay, just to make sure I understand what I'm hearing is the agency needs to, when we're looking at the procurement, look for a vendor that can support, if we're going to do interstate exchange, that has a large enough footprint to support that exchange.
Right, either already established or something that they can do, without a heavy lift. Exactly.
What can it do?
Yeah, I think that that's an important distinction. The ability to, whether existing, it's kind of a careful line we got to walk here, in my opinion, is that if we have an existing vendor who has capabilities, there are other vendors out there that also have capabilities, very similar in some cases. So we just have to decide what's important to Florida when we think about this, what is really important to us. And to be fair to everybody, but the ability to connect to data exchanges and a lot of statewide HIEs, there may not be current, but if you've done one or two, then they all look relatively the same. We just want to know, is that ADT interstate exchange and a requirement or the ability to make it so in the near future or so forth. So does that sound fair to everybody? I mean, okay. All right, let's move to consent policy because I think that's where all the bugs are. And I want to say that having done this, being part of the legal work group in 2011, 10, I think, is when we probably put all that together as the high-tech stuff was coming out. The legal work group, there are a lot of patient advocacy groups that participated in that. I don't know that they're currently on the legal work group, but for sure, they will be part of, I would assume, they will be part of the legal work group once word gets out that we're going in this direction. So we had to put that hat, maybe not on, but put it on the table while you're thinking about this. There are a lot of that, and that was really, I will say, that's why the retention of data was, we chose not to do that back in the day. There were a lot of, now that was 13 years ago, so a lot of things have changed. Technology has gotten better. There's a lot of things that have made things as improved. Data retention, data sharing that did not exist then. But with that said, it was a real challenge, and that's one of the reasons why that was abandoned by HIECC. And back in the day, it was just too much. And so those are why those policies have been adopted and still persist today. I'm just giving you a little bit of background. When I set through that, I was like, we're never going to get home if we go through this, but we ended up making it. So with that said, on the consent policy, we need to think about consent. The first thing right out of the gate is the consent to share versus consent to receive. And currently it's consent to receive. Do we want to continue with that policy for the new vendor, or do we want to pursue the other option, or both?
And the only input that I would have, Craig, is that if you're going to do interstate sharing, and if we're going to continue to share behavioral health data, you would have to move to a consent to share model. And the input the agency would like to have is, what is the technical and operational lift for all of these data sources? So we have over 800 data sources. So that's hospitals, that's skilled nursing facilities, that's hospices, home health agencies, the Department of Health. What change in policies would need to occur, especially since we've heard that hospitals are moving to an opt-out model. So they would have to revert back to an opt-in model for sharing data. And so what would be the impact, and both technically and operationally, right? So I know that through a lot of the EHR, those solutions, a lot of those solutions, the consent piece is done through the EHR. The patient signs, the consent, and it's electronically, and it goes directly into the EHR system. What is the impact with operational changes, technical changes, those types of things. And so those are things that we want input on. If we did say, hey, we definitely, have to have, unless there's a change in legislation, right, that allows us to share that mental health data for more than just treatment, right? Because the counter notification service is allowed for treatment, payment, and operations. And that is how we allow the providers and the payers and the ACOs to get that data, is because it's that fraud, and the law limits the sharing of that data without explicit consent only for treatment. So, maybe there's technical solutions there that we're not thinking of from the provider's perspective, but those are the things that we need input on. Gotcha.
Okay, that was a lot to unpack. Let me do something else to help with that. Brian, take off your current hat
Mhm.
and just put on your IT technical hat.
Yeah.
And give
Yeah.
me some background on the functionality.
Yeah, so I'm gonna lean a little bit on my counterparts here, Aaron Parsons and Chris Altworth, who are on the line as well. But from a technical standpoint, I can walk through this pretty well, what our current infrastructure looks like. So a couple things to note about the Florida HIE. If a health plan ACO provider group want to receive data, they provide patient panels. Those patient panels, essentially, we're making the assumption that they all have consent directly with the patient. And when they provide us that patient panel list, consent's been granted because the physician, the ACO, or the health plan have gone and gotten consent signature. And so therefore the data exchange. That data basically allows ADT data, including behavioral health data, to flow back to them because consent's been obtained. What we're looking to potentially adjust the model would be that the TPO data, treatment payment and operations data, which makes up majority, probably 90% of all the data that flows through the Florida HIE, that consent wouldn't be required. It could just flow. So ACOs, health plans, provider groups wouldn't need to go to patients and get the consent to receive that data. But behavioral health data would need to be consented. That would need to be something that a data center, a hospital, or a behavioral health unit, crisis stabilization unit would need to have the method in order to denote consent and say, yes, this patient's consented their data to flow through. Now, I will pause here for a second to chime in with Aaron Parsons or Chris Altworth to make sure I frame that correctly with what the current Florida HIE consent policy looks like and what potential the future would be if changes were implemented. Chris, Aaron, do you guys have anything you want to jump in on?
Nothing to add here.
No, I think there was an accurate summary.
Just for clarity, so you're saying that it would flow unless there is behavioral health data? You wouldn't need a consent unless, so. So how would a facility distinguish that and operationalize, hey, we're gonna send this data unless it has this data set in it? And would those folks that are getting the consent have the information needed, because you would be getting consent on the initiating side, I would think, before there is a diagnosis?
Yeah, I don't want to speak for Kim. She might be with the hospital association. You might know a lot more than I do, but I know how it works in other states in regards to consent. And we've also experienced this in Florida as well. There are typically 2 or 3 ways that that data is able to be consented. Either they denote it through a flag in the HL7 feed. The data center actually has a flag where they would be wired in to denote consent. They silo that data and filter it out because it's coming from a particular wing or department within the hospital. So all the other data may flow fine, but then they have a particular rule within their EHR system to say, if it comes from this wing or department, it needs to have a consent flag in it. And if it doesn't go out. And then the third way would be through a identifier. For example, they might have the same data flowing through the same pipe, but they have an identifier to say that if this particular data comes through, it needs to have a consent flag on it. Or if this data comes through this particular pipe, it's all been consented and it doesn't need to have a flag, because if it's coming through here, it's been consented. And that's something that we've worked with in other states and data centers, in Cleveland Clinic, Ascension, a lot of other organizations in other states, Minnesota and places like that, that have essentially Virginia attested and said, we've got this, we can handle the consent policy on our side. And most Epic and Cerner EHRs have moved to the opt-out model versus the opt-in, just the EHR, the new framework with the National Health Exchange and things like that. That's kind of where their models are going. but definitely open for questions and comments. Just that's kind of the framework.
Just looking at Dr. Bansal and could you make a comment to that on the consent policy?
So what I've seen currently is
Turn it
that
up.
it is a consent
It's up.
to share. Can you hear me?
You're a little bit weak. Go ahead.
How about now?
That's better.
Okay. So what I've seen currently in hospitals is that it's a consent to share. And so that example that I gave about an hour ago about another hospital, and let's say that I see that they've been there and I need to get the records, I'll request it from that hospital, but it still really goes back to the patient whether they consent to share that, or if they've done that before.
And this may be a question for the legal work group, but and I remember when we had the conversation years ago, and the determination was made to do consent to receive, it was because for opt-out, we could not guarantee that we were getting consent to share on the sending side. And so we would need to see where we could require, I mean, if there's an ability, maybe it could be through the ENS agreement that they would be required to do that, but also would opt out meet the explicit or express consent requirement in law for behavioral health data?
It was also a limitation on our legacy audacious technical infrastructure. We didn't have the ability to filter out between the two and authorized consent and wrote consent. That was something I think that was another issue, I believe.
Can you say that to the microphone? Brian was clarifying some stuff.
Yeah, I also think some of that limitations around the consent was on the legacy audacious inquiry infrastructure, that we weren't able to distinguish the sensitive information being provided and filter some out, let some in. So that was another thing that I think limited some capabilities on that.
Okay.
Like, I think it would have been a heavy technical lift on our infrastructure to have to build something like that and kind of manage it and maintain it, which we just didn't have the capability 6-7 years ago.
Pam, most health systems that I work with and that we exchange records with have gone to a model where they no longer require HIE sharing authorizations. You know, like 7-10 years ago, there was like a separate form that you would have to get with a signature at the point of care to allow record sharing, but everybody's kind of done away with that barrier, that extra hurdle. So what I see most folks are doing is that in the authorization for treatment, when you come in for the admission or the ED visit, it says on there, you know, there's a section that says, we may share your records with public health, with health information exchanges, with other providers for treatment purposes and so forth. And so as part of that authorization, you know, for treatment, you're agreeing to have your data shared with HIEs, whether that's, you know, Epic to Epic, EMR to EMR, or with an HIE in the case of ADT data. And then there's additional information about that sharing in the Notice of Privacy Practices that gets given once a year.
Marie, curious on your comment around, I don't know a ton about how the hospitals are actually doing this right now, but aren't majority of the facilities in the state of Florida already currently filtering out certain things in place? I know self-pay, I think some CFR Part 2. Now, I don't know if that's because it's under another wing or it's another department, so it's not within the siloed current.
Yeah.
So I wasn't sure if you have any, you know, technical information around that might be helpful.
Yeah, within the infrastructure that Epic has in their data sharing module called Care Everywhere, they have the ability to restrict encounter data from certain departments. So for example, we on a table, we add on there psychology, psychiatry, behavioral health, social work, genetics, etc., whatever we consider like a sensitive department. So then when somebody queries us for records, we don't share encounter data for those visits that took place in those departments. It really doesn't affect ADT data. It's really more just for the CCD exchange where you're getting the full clinical content, or in this case, restricting it.
That makes sense, since psychology notes can't be shared from the CCD side. So so what I heard, Marie, is that from your perspective, the hospitals you work with are have incorporated basically the HIE consent into the authorization, into the general authorization forms. It would be interesting to hear maybe from Peter, do you know if skilled nursing facilities are doing something similar? I know it's a little bit different because skilled nursing facilities have become residents of the facility unless it's, I'm assuming unless it's for rehab purposes.
Yeah, and so I will have to check to find exactly what current practice is around consent. We certainly design consent around admissions processes. But again, part of the discussion here is the extent of that consent to mental health issues. We frankly would say in our settings, everybody in effect opts in. I mean, because you explicitly do consent. But again, on the specific issue of consent to share versus consent to receive, for example, I have to do additional research.
Well,
I was just going to state, I know the skilled nursing facilities that are on the point of care EMR are following the current consent model that we have from as a whole. So they typically go in and they sign the consent form to authorize data to flow into the point of care national network.
Well, the way it was originally set up, and by the way, we're kind of we're kind of flirting here with clinical data and not the electronic. But let me just make a distinguish something on the clinical component of it. I know this for sure is what everybody was always opted in, and then at the treatment facility was an opt out. So for treatment purposes, that's when you got essentially the authorization for your physician to view data. That was built all the way around as someone, patient privacy advocates said, I maybe necessarily do not want to see. I mean, this was some of the thinking on it. I don't want you to know that I went to the specialist that is embarrassing and or whatever it was. I don't at that point in time, but when they show up 4 days later in emergency room, now actually I do need you to see that because I got medications that you want. So that was the whole point of that op-ed for during treatment. Point of care, sorry. Now, with that said, is so, and that's and also we talked about some of our not all EMRs are created equally, and we have to make sure that we're naming some Lamborghinis that have a lot of this figured out. Not all EMRs have that figured out, and we're relying on them as the ADT suppliers, and not. So you get it. We really, there's a big spectrum of capabilities, and as an IT person, which I'm not, but I do know that there's the data is not all the same, and the way it comes out. And so you can't build specs for the Lamborghinis that can beat those, and when the 80% that that other hospitals can ever, as far as what we're trying to do on patient consent, patient proceeding. I just want to bring that up. Now, back to the electronic notification, which is really what we're talking about, is the ADTs are coming out, but differences that are going, someone's subscribing to that, get that data. And so that's why I think we chose to receive, to make sure that they had authorization for whatever the subscriber, because that data is coming out pure, minus behavioral health at the time, and then receiving. Is this why I was trying to get to the logic of why it is what we're trying to change on the logic? And
Well,
am I stumbling on it?
no, I think you articulated it correctly. So right now, we do consent to receive because we are not filtering out, behavioral health data. We're not filtering out mental health data. If someone is treated at an emergency department and there's behavioral health data provided there, and it flows through the account notification system, in order to meet the provisions of law, we do require that there is consent on the receiving side, because we cannot guarantee that there was consent on the sharing side. And so that was the kind of the reasoning behind why that model was used. I know there was conversation years ago about, even on when we were doing the hub model and sharing, looking at sharing CCDs, there was actually conversation about opt-in versus the opt-out, or to getting consent to share the data for the CCD side. And I've provided this, I think we provide this information in your member information that we shared with you. And there was a push by the agency to require the opt-in or the consent to share model for CCD exchange, because that opt-in was really kind of what was happening nationally. And then I think we got so much pushback from providers that we moved back to the consent to receive. Of course, that was CCD exchange. It's a little bit different. You know, the main focus here is around the behavioral health data and how we can help providers meet that provision of law. We don't want to put providers in a position where they are violating, you know, a provision of law, even unintentionally, right?
Pam, could I ask a clarification? When you talk about behavioral health data, what is the requirement? Is it, you know, a simple, like a diagnosis at the time of admission, that is what needs to be protected, versus like all of the visit notes and, you know, treatment plan and medications and everything else? You know, because obviously what goes in the ADT message is very limited as opposed to what goes in the CCD.
So in the Mental Health Act law, it basically says the sharing that there has to be express consent by the patient in order to share mental health data. And that is what it says. So if there is, yes, a diagnosis of mental health disorder in the emergency department, there would need to be consent for that to be shared.
Okay, so if the
And
patient,
I don't know if Linda McDonald is on for the Behavioral Health Association, so I don't know if Linda has input into that.
Yeah, she's on.
Yeah,
Linda?
I think what you said is accurate. I wish Melanie could be here to talk a little more in depth. And I'll be, you know, sharing back with her, but the consent policy is very explicit. There has to be express consent to share data. So.
and that would be, Linda, you know, if the admitting diagnosis is depression, for example, that would be enough, that has to be protected if there was no other clinical content besides just that diagnosis.
Oh, yeah.
Okay, thank you.
I'm a little confused when you were saying, I may have misheard. So it's the obligation of the receiving end to get the consent versus the hospital's end to get the consent to share?
Please tell us your name, sorry.
Kim Tendrich.
Ah.
I'm confused on the consent end for that type of
The consent
health
end right
information.
now to get the encounter notification data, Kim, is consent on the receiving end. So if you have, if you are a provider and you are getting, you currently should be getting consent to put your patient on a patient panel to receive that data.
Okay. Okay, got it. Thank you.
Fab, you have made a comment. Can you please explain what you have said?
Yeah, just thinking that with the diagnosis is one risk, but I think there's a disposition code that says being released to a psych unit, I believe, 93 or something like that.
Yep, that's correct.
Yeah.
Can I?
Again, go, yeah, yes, sir, go ahead.
Yeah, and I think all these are great points. One other thing I just was bringing up, if we look at it from a different angle, you know, we're here to serve and protect Floridians. The potential adjustment of this consent model would also empower a lot of the patients in Florida to take control of their consent. Versus right now, it's more of once a provider has that signature, they submit a patient panel, they get all the ADTs on that. And we often at the Florida HIE have patients reach out to us directly asking, can you remove my data from the HIE? Can you remove my consent? And majority of the time we can't. We tell them you have to go to your PCP, your health plan, and your ACO and tell them to remove you from their patient panel, and you have to revoke consent to them. So this potential change would empower whatever vendor can take control of this to be able to manage and maintain that by physically removing the patient from the HIE database and blocking any additional data coming in. So just another thing that maybe empowers some patients a little bit more in the state of Florida.
So could you explain that a little bit more? Because so a patient providing consent on the sharing end versus the receiving end, how does the vendor have control over that?
Right now, if a patient reaches out to us to say, please remove my data from the Florida HIE, and I don't want my data to flow to my PCP, health plan, or ACO, we had at the vendor level, we have no control of that because the data flows out of the hospital. And as soon as it flows, if that patient is in the MPI and is subscribed to a subscriber, that data is going to that subscriber. Until that subscriber removes that patient from the roster, that data is going to continue to flow. And there's nothing we can do about it at the system level.
Because there could be so many people subscribed to that individual, or because, so I'm trying to understand the technical capability of
It's
you
the
being able
output,
to.
they can't control the output.
Yeah.
Okay, you
Yeah.
can control the.
Right now, we can't,
Or basically.
yeah, right now, we're getting all the ADTs out of Nemours, for example, 100% of them.
Mhm.
We can't control that data going downstream to a subscriber, because if the subscriber provides us a patient panel with that person on their roster, even though the patient said, I don't want you to send this to my PCP, or I don't want this to go to my health plan, because the health plan and the PCP are providing us that patient on the roster, that data is going to flow to them no matter what. If it's changed on the other side, then not only the data sender has the option to say this patient's revoked consent and that data does not flow to the HIE. Also, the patient can come directly to the vendor in this model and say, I would like to remove my data from the HIE and block any future ADTs hitting the system going outbound.
Because it would be off the master patient index.
Exactly.
Okay,
Exactly.
thank you, that's what I wasn't getting.
Yeah, it just empowers the patient on the Florida side to go in and you know have a say in it.
That's an interesting comment. Probably easier to just call the receiver to give him, how many of those happen a year?
Quite a bit. I mean, I probably get 1 or 2 a month at least.
Okay.
I mean, so I mean, it's not hundreds or.
So out of 26 million people we're talking
Yeah,
about.
yeah, you're right, you're right. But I think that, sorry. I think the thing for me and the people that have worked on this for years and years and years, and I'm going on 9 years working on this HIE, to tell them no, kind of pass the buck is always something that we typically don't like to do. I mean, you and I talk a lot. We have a lot of folks on the call that email me directly with problems and things they need fixed, and I have to tell them I can't. And frankly, I don't even know sometimes who their PCP is, who their health plan is, because I can't, I don't have that purview into that where I can look it up and figure out who they are. So they may say that, why is this provider getting my alerts that I haven't seen in a year and a half? And it's like, well, maybe that provider didn't authorize and hasn't updated their panel as they should and taken you off because they haven't gotten consent. And it just, the idea that it puts it back in the patient's hands, and at the time of an encounter in a hospital, they can tell the hospital, I don't want this data to flow away. Yeah. Something to think about.
Yeah, you can get into a bunch of use cases on consents that, and that's why I asked you to put on or not put on the hat, but at least set it on the table, these patient advocates, patient privacy advocates, and how we think too, especially if we're going to send alerts to Minnesota. So he just brought up the reason why. Consent gaming.
Yeah, and I think, Craig, the volume is not large, but the population that asks for opt-out has very strong feelings and very strong views. So they're very vocal, and so it can be quite a challenge, I think, for your organization's reputation and potentially legal ramifications, even though it's, a very small minority.
Well, Marie, you just hit it, and that is exactly why we did that 13 years ago, is because you're right. It is a small group, but they are very loud and very, very strong in advocacy. So you have to think, you have to think about it. I don't want to belabor this point. Do you feel like Pam, do you feel like we've given enough feedback from the group? To open it up for additional comments or clarifications from the group to?
I really don't have any clarity on the billing of, or I mean, are there any? So what I've heard is we need to be cognizant of, patient advocacy, right? And, their ability, to opt out of sharing their data. And are there any other considerations as far as providers, that have gone to the opt-out model, and or use EHR systems that are not the Lamborghinis like Epic and, PCC? What considerations does the agency need to look at for that? And what are the implications of saying, hey, if you want to participate, you need to do opt-in, for those hospitals that have just transitioned over to opt-out?
I know the hospital will fall over. Is there a reason enough to change the current consent policy?
That's the question.
That's the question. So we've heard enough of the discussion. Is there the current policy is consent to receive, meaning the folks that are providing the panel is getting consent to receive that ADT data. Is there enough what we've heard to change that current policy? And if so, to change it, is there additional information? We've heard some good information, so they're taking notes on that. But is there a feeling from this group to push that discussion further. Tim?
So Craig, this is Bruce, I got just one comment real quick. For public health reporting purposes, we do get that data for syndromic surveillance. And I don't think we would want patients opting out of that, that reporting. So that would be a consideration at this point. Now, we have other ways. We have electronic case reporting to get, data regardless of consent. But that is we want to make sure we're getting all the information we need for those public health related purposes.
Good point, Bruce. And in the current setup, that allows for that. If we change to consent to send, that may make that less optimal, correct?
That's correct.
So just to make sure I'm understanding, with the current consent model, consent to receive, a health system could continue to send you ADTs without getting that explicit consent. Okay.
Well, Marie, they get the consent. I mean, it's just like you said, every health system, I think, does this. I don't know. You could probably speak to that. I don't know if she knows the intake model, but specifically, but most of them all say exactly what you said earlier. For treatment purposes, we may share your information with health information exchanges, et cetera, for better patient service. So, and they all do that. I'm pretty confident in that. So that's how they're sending it outbound through to lockdown or to the ENS, electronic notification, to the ADT repository. So.
Yeah, what I'm thinking is, at least for example, with Epic, it's easy to stop the sharing of CCDs, but it's not as easy to stop the sharing of ADTs.
Right.
Pam, you look puzzled.
Yeah, is why. My question is, why is it why is it hard to?
Well, within the Epic system, the module for sharing records has a very easy on and off flag for sharing and receiving of CCDs. But, the ADT messages don't come out of that module. That's like through your interface engine. So it's kind of like a totally different infrastructure. Does that make sense?
Yes, thank you.
Any other additional comments to that?
There it is.
Yes.
So one other point to bring up, which has actually been something that we've heard from a lot of providers, and some ACOs, mainly providers though, with the Florida HIE, is they have trouble obtaining consent for patients that have been assigned to their PCP group. And they can't put them on the roster because they haven't seen them yet. So they have to wait until they come in for their first visit, maybe their annual wellness visit or something like that. So there could be 3, 4, 5 months before they actually are able to get them in the doors when they're a net new patient. So something else to think about, that maybe changing things a little bit on its head might allow for data to flow a little more freely, letting these new provider groups that have never seen this patient, but they are assigned to them because they enroll with the new health plan and they pick the PCP, but they just haven't had a chance to actually get them to execute consent. So again, something else to think about with that the burden on the providers is going to be significantly lower with them having to get that. And and some of that high risk population, I think Medicaid, really hard, I think, to capture consent.
Maria, I have a question for you based on your comment about the technical capability within your EHRs, within the EHR system, Epic EHR system. So saying that it's harder to stop the flow of ADT data, so that does that mean that moving to an opt-in model, I mean, what would that, implementing something like that, and and having that consent to share mean you already get consent to share, correct? It's through your authorization.
Correct. Mm-hmm.
Okay, and so if somebody says, I don't want that data shared, and it's specific to, can they do specific to behavioral health data, or is it you're open to sharing your information or you're not open to sharing your information?
I mean, in general, the options are they can opt out of sharing or receiving. So if they don't want other organizations to get our data, we can opt them out of sharing. Or if they don't want us to get other data from external systems, we can opt them out of receiving. That's sort of like the two switches that Epic has. Now, within that, you can build rules. So we have built some rules. Like if the patient's deceased, for example, we don't allow somebody to query us for records if the patient has a status of deceased. So you can build rules around that. But as I mentioned earlier, that's really more around, sharing the continuity of care summaries as opposed to the ADT messages. That's sort of outside of the Epic infrastructure.
So you have to build rules around the ADT infrastructure separately.
Correct.
And so with the ADT infrastructure, if somebody opted out, you have to develop a technical solution to allow for that.
Correct. We would have to, yes. The only filtering that I think we're doing on the ADTs right now is, Brian alluded to it, is self-pay for the self-pay visits.
So there would be a technological impact on data sources in developing a solution for moving to that consent to share.
Just a follow-up question for Marie. I may be wrong in this, but I've always been under the impression from the EHRs that we've dealt with over the years that there is always a opt-out flag available in the ADT feed. And the real, I'm going to say maybe hurdle would be to make sure that the workflow within the hospital denotes that and actually captures it. I may have that backwards and my understanding is incorrect, but from a technical standpoint, I always been under the impression that all EHRs have an opt-out capability where it can be something where they filter it out. But I thought more on the workflow side of it would have been maybe a bit more of a lift on facilities.
Yeah, I mean, that's really more outside of the functionality I was mentioning, Brian, outside of the Epic application for data exchange. Certainly, you can, if you have a field within your registration record for a patient that says opt out, and then you can map that to the ADT segment that has that opt out flag, you can do it what you're describing. I don't know how many health systems have implemented that opt-out flag, but it's certainly capable. But that goes to Pam's point that it would require some technical work. And then to Bruce's point, we would want to make sure that the ADT feed that goes for ENS purposes has the opt-out, but the ENS feed that goes to syndromic surveillance doesn't.
We have over 800 data sources. What?
856.
Yeah, 856-ish.
Yeah, I'm not trying to impose anything, but I just feel like, we have 850, you want that flowing with little or no additional requirements from the hospitals, just get it out the door. And then the subscribers, it's on them to get the, because it's easy, that's a smaller, I mean, that's a lot of data flowing out the door, and not everybody, and I think you still want it going, as much as you can without putting additional consents in place.
So that would impact the ability to share data across interstate,
Correct.
because you would have to get the receiving providers in other states to do consent. And that is why we have not been able to share data across state previously. So that's something that, and that's why it's really kind of tied together. And then also retention of data outside of Florida, if it's on a vendor hosted integration, being able to, well, it's kind of tied to cross-state data sharing. So,
If it's on a vendor, it is more able to share.
no, it would be, it would be like, so if the model right now, so if Point Click Care's model right now would be, okay, all of the providers in Florida would share data with all of the providers in every other state that Point Click Care has an agreement with. And this is just an example. That would be interstate, right? And so you would have to have a consent model that would meet the requirements of those other states, as well as meeting our requirement for sharing mental health data in Florida, which would have to be that consent to share, consent to share model.
Yeah, I mean, the way you would think about it is all these providers in other states would have to essentially submit a patient panel just to the Florida HIE in order to do that.
So with if they go with an opt-out on the hospital side, or the opt-out approach, with the exception of mental health, and again, that's going to be a lift on the hospital side, would that solve it? Where, and whatever the consent.
Yeah, go ahead, finish your question.
So like, I'm just trying, because I think that the more that we put on, like, if the hospitals have moved to opt out, trying to get them to go back, it's not going to be that. I think that that's going to be a heavy lift. I'm assuming that they've got the protection in there for the mental health. But if they do have that, like, I guess I'm struggling with the ability to share. If it's an opt out on when they first have contact with the patient, does that would we need definite consent one way, either on the sender or the receiver? I guess that's what I'm confused about.
Yeah, as I was trying to articulate, and I think Linda confirmed for us, is that the law is pretty specific that you need expressed consent to share mental health data. And so you would have to have it on one side or another. So an opt-out would not necessarily meet that provision of law, because it's not an expressed consent, because they're sharing without giving you actual consent. Did I say that correctly, Linda?
Yes, you did. You're very articulate. Thanks.
So, your question about if we did not share mental health data or behavioral health data, I know there are some states that I actually ask folks to filter out that data. But I would go back to what folks that we got feedback from said is that it's more important for them to get that behavioral health data and mental health data than it is for them to get interstate data. Also, we have crisis stabilization units that share data. So they specifically share mental health data.
And they have to get the receiver has to get the consent.
Correct.
Hi, this is Kim from Department of Health. Along with behavioral health information, isn't family planning from a teen perspective? Well, I shouldn't ask the question. Family planning from a teen perspective is also super confidential. I guess it could go to providers as long as it doesn't go to parents or guardians, but HIV information as well, there needs to be express consent.
Yeah, to your answer to that question, that's considered sensitive information as well, which needs express consent in basically any national model.
Oh, it's complicated. Putting it out there. I just, if I'm buying a patient panel, put it another way, if I'm buying a patient panel, there's a 90% chance or 99% chance right now that I will get alerts on the patients. If I buy a patient panel now, in the new form, there is less than a 99% chance because the hospital would have to go get the consents to send. And when does that happen? Well, when they arrive. So it's not an easy, like and I feel like I'm Debbie Downer on the new policy, but I understand why we want to do it. It's complex.
Yeah, I mean, I think to your point, it's the burden's either on the hospital to build this consent model initially, and I think majority of them already have a lot of this in place, or it's on all the providers and ACOs and health plans to continue to capture consent, continue to get this consent. But the ability for CFR Part 2 data to be contributed into the network, I also think is a benefit for everyone involved, and the ability for a patient to control that data and alert whether it's going to be allowed in or not, I think could be a benefit for providers, ACOs, and health plans too. So, yeah, just other thing to think about.
Yeah.
So right now, if we stick with the status quo, the drawback is this interstate sharing.
And Part 2 data.
And substance use disorder data. So so there is the potential that we could, because in a new system or in an improved system, or with whatever vendor we're going with, we could require that
Everything
consent would flow with the data. One of the reasons we couldn't share, we required facilities to filter out substance use disorder data is because there was no way for us to have the consent follow the substance use disorder information, which is required federally. So that data is not shared at all in HIE. It's a little bit more complicated, so I'm adding more complexity to this. So, but if you've got consent on the sharing side, right, you would be able to share data interstate, because we know that there, is consent. And then also we would be able to potentially, depending on who the vendor is, be able to flag that information, flag the consent along to follow the substance use disorder information, as well as other mental health disorder data.
So it sounds like your recommendation is.
I'm not recommending anything. I'm looking for input from this body.
complicated.
Yes.
Yes.
Everybody online that's,
Yeah.
Nobody's making comments?
No.
Everybody's fully. Yeah. All right, well, we'll just stop there because we can talk. I'm glad we had the discussion. I mean, because it's gonna come back. It's going back to legal working group and then probably at the next HIECC meeting, we'll have some updates on all that. I would assume that's correct.
is, I'm hearing that as a action item from this committee that the considerations around consent that were discussed here go to the legal work group for input.
Everybody okay with that? Right.
Agree.
Agree.
Any further comments? Okay. Next agenda item is the 2024 HIECC meeting dates. Okay. Oh, it's up there on the screen.
So these are the proposed dates. And so that is Wednesday, February 14th, Wednesday, May 8th, Thursday, August 8th, and Wednesday, November 13th.
Is it the same 12 to 4?
No.
Okay.
This was a special meeting. We will not do this again to anybody. Again, well, I shouldn't say that.
Yeah.
I'm not gonna say that, but well, our intention is to never do this again as far as this, but thank you so much for participating for this long. I mean, really, honestly, it's, but this is the kind of input ACA needs from the group. They just do. So I appreciate that. Some kind of public comments.
No.
Are there any concerns with the meeting dates from the members?
No.
No.
Okay, hearing none, I assume that Pam will send the calendar invites out, so it's on your Outlook calendars. Public comment.
Yet.
I think Diane Godfrey made
Yes.
some public comments previously, but she had to leave.
Okay.
Should
I share that here? Yeah.
See if there's anything other than I agree. You did have Diane did have a question about how you would get data from other states. And so that would be the vendor for the encountered or for the service, the ADT service in Florida would work that out and mesh that data in for patients in other states. And I think everything else was, I agree, or comments like that, so.
Pam, meeting summary and next steps.
Okay. So, what we heard, I think, is that for data retention, there was not any opposition for data retention as long as there's security, no monetization of the data, and there are security measures in place. As far as interstate data exchange, there was interest for interstate data exchange. And then as far as consent goes, we're to bring that to the legal work group for some of the considerations that the committee brought up. Specifically, information around, confirming that the opt-out model would not meet that explicit consent requirement. And any other legal input that they have around the consent policy, the implications to public health and them getting the data that they need, and concerns that data may be impacted with a consent to share model. I think that was a majority. Then basically it is a complex issue. And then, yeah, I mean, we can provide the pros and cons. Definitely, there were definite pros and cons of both sides, right? Of the consent to share and consent to receive. The reduced burden on practitioners to get the consents, the ability to share 42 CFR data, if it is consent to share, but then also the technical complexities with changing those models for the data sources as well. Technical and operational considerations.
In empowering the patients
And yes, the ability for the patient to be able to have more control over data sharing. So from that, we will have the conversation about consent. I don't know that we have, I'll have to look at the legal work group agenda. Our meeting is Friday, and I don't know that we have not provided them specific material on the patient consent. We can broach the topic, but we probably have to schedule another meeting for them to have a specific conversation about that.
Final call? No, I think that's it. Final call? Hearing none, motion to adjourn. Thank you, Kim.
Second.
Hey, we are 33 minutes early. All right, have a great night, and we'll send out information. See you February 18th. 14th. Oh, okay, yeah.
Valentine's Day.
February 14th.
Get an easy pass.
Nice.
Thank
Have a
you.
great day. Thank you so
Thank
much.
you all. Thank you all.
Bye-bye.
Thank you.